Uh, Good morning, everybody, and welcome to our Inherited Metabolic Disease and Coronavirus webinar. Hopefully, this will be able to give everyone an opportunity to learn more about how this global pandemic will affect ourselves as members of the metabolic disease community and equip it with information and resources that hopefully will be able to navigate these unprecedented and scary forthcoming weeks, feeling more confident in what we should do and where we should ask for information. My name is Will Evans. I'm the chairman of NP UK, Niemann-Pick UK. I have a child, Sam, who has Niemann-Pick type C, and I'm also a GP in Yorkshire. We're very fortunate. Next slide, please. So just a little bit about the format of this. We're going to have quite a series of different talks from different experts who I'll introduce in a moment. And during that, there's the opportunity through Zoom to pose questions in the question and answer bit that you should be able to see at the bottom of your screen. Now, we will, for obvious reasons, we've got over 300 attendees. We won't be able to address all the questions, and certainly not specific patient or condition questions. The answers to those will obviously be addressed by your treating physician. But general questions, we will, if we're unable to answer them today, will be collated, and we will try to give responses to those after the meeting has ended. As always, please do contact your patient organisation for practical social care and other support and further information. Next slide, please. So we're very fortunate to have an expert panel with clinicians with great expertise looking after both adults and children with metabolic diseases. We have Dr. Robin Lachman, who's a consultant in metabolic medicine in London at the National Hospital for Neurology and Neurosurgery. We also have Dr. Roshni Vara, who's a pediatric inherited metabolic disease consultant, also in London at the Evelina Children's Hospital. She's also a trustee of Metabolic Support UK. Dr. Elaine Murphy is a colleague of Dr. Robin Lachman's at the Charles Dent Metabolic Unit at the National Hospital for Neurology and Neurosurgery. We also have Dr. Simon Jones, a consultant paediatrician in inherited metabolic disease at the Willink Unit in Manchester. And we're also very fortunate to have Dr. Lynn Aikenhead, who's a clinical psychologist who works at the Charles Dent Metabolic Unit, who will be able to give us some insight about psychological support, guidance and advice and resources to help us through this difficult time. Next slide, please. So I'll now pass over to Dr. Robin Lachman, who will give us a little bit of information about what coronavirus is, how it's spread, and who is at high risk.
Thanks, Will. So this is the severe acute respiratory syndrome coronavirus 2, which is what's causing all the problems we have at the moment. It's a virus, and a virus is really just a package, a tiny little package, which contains a number of genes. And all it can do on its own is find a host, which in this case is us, and try and find a cell within that host to infect. And when it infects that cell, then it actually starts doing what it does, and that's to take over the machinery of that cell in order to reproduce itself. So it takes over the cell, and instead of the cell doing what it normally does, it starts to produce more virus particles. And eventually those virus particles are released from the cell, and they can go on and infect other cells next door, so the infection spreads through the host. And also they can be released back outside into the environment to infect other people, so that the virus can spread from one host to another host. And that's really what viruses do. They're very simple organisms, but they can wreak a lot of damage, because when they take over those individual cells, they stop the cells from doing what they're supposed to be doing, and in many cases end up killing the cells, and that's what causes disease. Next slide, please. Why haven't we seen this before? Why is this virus new? Well, this is the virus an example of what we call a zoonoses. And zoonoses are diseases that pass from animals into humans. So these are viruses in this case that are normally circulating between animals, and we don't know in this case which animal it was, but we think it was somewhere in China. And at some point they managed to cross over into the human population, and then in the case of this coronavirus, they can pass from human to human without having to go back into animals again, and they then become a human disease. And the disease, next slide, we're dealing with is COVID-19. So COVID-19 is the disease, coronavirus infectious disease. And it is very similar to flu, or in some people actually to something that isn't even as severe as flu, just a cold. Patients will get fever and a cough, and some patients will then go on to develop involvement of the lungs, and they'll get shortness of breath. They'll get death of cells within the lungs. They'll get a lot of inflammation within the lungs, which is your body's immune system trying to deal with the virus. And that leads to the pneumonia that actually is causing the major problems with this disease, and it's the cause of mortality in some patients. Next slide, please. How's it passed around? Well, it's passed around in a very similar way to other respiratory viruses, the common cold, flu, which is by droplet spread. So when you cough or sneeze or even just breathe, you produce droplets that go out into the air and contain the virus. And this can be passed on to other people either because they're close by and they breathe in those droplets themselves, which gives them access to their lungs and their mucous membranes, or they can get into their eyes and get in that way. Or alternatively, they can pick it up without having to be particularly close to you, because these droplets can fall onto other surfaces and objects, particularly if they're on your hand. You can then put them onto doorknobs, keyboards, tables. And because the virus is relatively stable and can survive outside the body for a number of hours, perhaps even days, other people can then pick it up if they touch those things and then touch their face. And that's why we're being told not to touch our faces, to try and avoid touching surfaces that haven't been cleaned. And that's the way the virus spreads around from one individual to another. Next slide, please. And that's why we're getting the advice we're getting here from the CDC in the States, but it's the same advice in every country, in trying to stop the spread of germs by making sure that if you cough or sneeze, you cough into a tissue, which goes straight into the bin. You don't cough onto your hands so that you're not leaving droplets on surfaces. You're not touching your eyes, nose, and mouth. That's not because you've got the virus yourself, but if you've been going around touching other things, that then gives you a chance to introduce the virus into yourself, and that you clean everything down. And all of those are ways to try and stop this from spreading around, because it is a very infectious virus. And each individual is going on to infect many other individuals. And we need to try and stop that spread. Next slide, please. Because it's very infectious, we are seeing a lot of cases. And this virus is now really established in a lot of different countries in the world, and it's causing disease in a lot of people. It's worth bearing in mind that the vast majority of that disease is mild. Most patients will have a cough or a cold or some flu-like symptoms and not need to seek any medical care. This data relates to the initial Chinese outbreak, where they were reckoning that about 15% of cases perhaps were severe enough to require some kind of hospital care, and perhaps 5% of cases developed a pneumonia that was severe enough that patients were going to require help with their breathing and would end up on intensive care units, getting oxygen, and in the worst cases, having tubes put down their throats to help with their breathing. But it's worth bearing in mind that that's a small proportion of the cases, and that it's an even smaller proportion of the cases who have severe disease and end up dying of this condition. And on the other side of the slide from the pyramid, you can see a graph again from the Chinese data in blue, showing you the number of cases at different ages. And certainly when you look at patients, and this is testing patients who are symptomatic, so most of the symptomatic patients seem to be middle-aged. There are a lot of cases in middle-aged patients, but the deaths are really very much concentrated in the elderly. So a very vulnerable population of the over 70s, where most of the morbidity of this is, and the vast majority of younger patients are having a mild or symptomless disease. There will be some patients younger who get severe disease, but that's a factor of the fact that there are just so many patients being involved. Next slide, please. It's also worth bearing that all of the data you see on number of patients who are infected are based on patients who've been tested. So if you don't test a patient, you can't tell whether they're infected or not. And different countries have different testing regimes, but in the UK, certainly we have only been testing patients who are symptomatic and in hospital, really. And therefore, there are a lot of patients out there in the community who are infected. Many of them now will be self-isolating, who've never been tested, and so they don't come up in the statistics. And so we're missing an awful lot of patients with mild disease who haven't been tested, and it's likely that the result of those patients is actually will bring down the percentage of patients with infection who are really needing hospital care or who are going to die. And that's worth bearing in mind. Next slide, please. This virus has now spread throughout the globe. It's a pandemic. There's a graph here showing the number of cases, again, the number of tested cases who've been reported. It's a bit out of date now, and the number of countries. And there's no doubt that air travel and things probably makes it easier for viruses like this to get around than it used to be. But it's worth bearing in mind that back in the Middle Ages, when we had plague, and nobody had aeroplanes or cars, people just got around mostly by walking or going horseback, the plague was still able to spread throughout the whole of the known world very quickly in a season in those days. So these infectious diseases get around anyway. And travel isn't, the fact that we can now travel by aeroplanes isn't really the major thing that's driving that. Next slide, please. So these are data for the UK, where we are, showing how these epidemics take off and then seem to rise completely out of control. And that's because this virus is so infectious. They reckon that every person who gets infected infects at least 2 more people. And therefore you see the virus doubling every day or 2. And that's why the numbers seem to take off. And again, there are probably more numbers than this, probably at least 10 times as many, maybe 50 times as many, because we're not testing patients who have mild infection. And the virus is spreading throughout the country. Certainly there's much more going on in London at the moment, but it will be present everywhere. And that's inevitable. Next slide, please. So what's the response to this been? Well, if you were going to design a healthcare system to deal with something like this, you would come up with something very much like the NHS and Public Health England. And we've been preparing for this now for many weeks. The NHS has been clearing the decks. So we've stopped doing a lot of routine stuff. We've stopped doing outpatient visits. We're doing telephone calls. And that's really to get ready for the large number of cases we're expecting to see. And the public health response has been aimed at 2 main things, really. Protecting those who are most vulnerable to this disease, the ones who are most likely to develop severe disease, the ones who are most likely to die if they get this infection. And secondly, protecting the health service. Because the problem for the health service is we only have a certain number of intensive care beds. We're trying to ramp that up as much as we can, but there's always going to be a ceiling. And if you have an epidemic that isn't controlled at all, and everybody gets ill within the same 3 or 4 weeks, a month or 2 perhaps, then you're at danger of completely overwhelming your healthcare system. All your ventilators will be full, all the beds in hospital will be full, and you'll get people who aren't getting the care they need, and therefore at increased risk of developing severe illness and dying. Whereas if you can spread that epidemic out over several months and keep the numbers down so that you have probably the same number of people requiring care, but over a longer period, then hopefully you'll have a chance to ventilate people for them to get better, to go home again, and you'll be able to hopefully maintain things within the capacity of the system. So we're trying to protect the most vulnerable patients, and everybody else then is having to try and protect the health service to make things better. Next slide, please. So the advice is all about how to avoid catching and how to avoid spreading the virus. And it's really the spreading the virus that's the most important thing. Catching the virus, the vast majority of people are going to have a mild disease, but we don't want to spread it to people who might be at particular risk. And we don't want everybody getting ill within a short period of time and overwhelming the health system. And that's what the social distancing advice is all about. This is everybody having to do what they can to stop coronavirus spreading, not to protect themselves, but to protect everybody else. And that advice has been in the UK in place for a couple of weeks now. Initially, it was aimed particularly at vulnerable groups, the elderly, those with long-term conditions. But now really everybody should be doing this because it's the only way we're going to be able to manage to keep things in place. Next slide, please. Just over the weekend, NHS England and Public Health England have issued new guidance on shielding and protecting people who are at particularly high risk, extremely vulnerable from COVID-19. So at the moment, we've got social distancing, which everyone should be doing to try and stop the spread of the virus around the community. We've got self-isolation, which is what people do if they think they have the virus, or if somebody in the family has the virus, which is staying at home in order to try and stop it from being spread. And certainly at least one of the panelists here, I think Simon, is self-isolating at the moment. And now we've got shielding, another S, which is what's being suggested for people who are particularly vulnerable. Next slide, please. So what do we mean by extremely vulnerable? This was published in the UK online yesterday. And this is a list of the groups of patients who are being treated as being extremely vulnerable to this virus, extremely likely to get a severe viral infection and therefore need ITU care in hospital, and who are being advised to undertake shielding. And they're patients with a number of different problems, but a large group of patients who have problems with their immune system. So those who've had organ transplants, for instance, will be on immunosuppressive drugs. Groups of patients with cancer who are having therapies, chemotherapies and other therapies that affect the immune system and therefore put them at increased risk. The second group of people are people with underlying respiratory disease. So you have underlying lung disease, that puts you at increased risk of getting a severe pneumonia with this infection. Next slide, please. And also on this list, number 4 in the list, there's a group of people with rare diseases and inborn errors of metabolism that significantly increase the risk of infections. And then they give a couple of examples that aren't actually inborn errors of metabolism. So we have got on the list a recognition that there are some people who have inborn errors of metabolism, the diseases we're dealing with, who are going to be extremely vulnerable. But it's only a minority of them, a proportion, those who are significantly increased to the risk of infection. And that's not set out in this list. So how are we going to know who those patients are, who it is who's being recommended to consider taking this action? Next slide, please. Well, when we were thinking about this and when we were feeding into NHS England about who these patients should be, there were 2 things we were really thinking about. There's a group of patients who are at high risk of getting a serious coronavirus infection. And those are the ones who either have underlying respiratory disease, and there are some examples there of some of the diseases that give you respiratory problems, either because you've got weak muscles in Pompe disease or glycogen storage disease type 3. You've got lung disease as part of your disease, like Niemann-Pick type B, or in the mucopolysaccharidoses, you have lung disease and problems with your airways that make intubating people, if they need care on ITU, extremely difficult. And those are just some examples of conditions where the underlying respiratory problem puts you at particularly high risk. We also have a group of patients who are immunosuppressed. A number of those are immunosuppressed because they've had transplants and therefore on immunosuppressive drugs. We've got patients who've had bone marrow transplants, but actually if you've had a successful bone marrow transplant, then the advice is that if you're 6 months out and you've got good engraftment, then you're probably not at increased risk because your immune system's working again. And there are a few diseases where immune suppression may be part of the disease. We've got patients who've had splenectomies, for instance, which may make people more likely to get a severe infection. So that's one group of patients, those who are at high risk of a serious coronavirus infection and therefore extremely vulnerable. The other group of patients are a bit different. We don't think they're at particularly high risk of getting a severe coronavirus infection. It's likely that the viral infection, if and when they get it, will be mild. Like most other viral infections, they'll end up with a cold or a bit of flu. But for these patients, that brings with it a risk of metabolic decompensation. So these are the are at risk of decompensating. The diseases where we any more sick with the coronavirus, but right now, when the healthcare system is under such stress and when the hospitals are full of extremely sick people who have coronavirus, we really don't want those patients turning up in A&Es unnecessarily. And particularly patients who are metabolically very brittle, who have frequent decompensations, you're really going to be an extremely bad place if you're having to go into a hospital that's busy doing other things. So we are also regarding a number of these patients, the ones who decompensate frequently, as being at high risk because we don't really want you having to go into hospital unnecessarily at this point. And the way to avoid that is to avoid getting the coronavirus. There will be patients in these groups who are metabolically stable with milder disease, if you like, who may not be extremely vulnerable, and other ones who are. And it's going to be up to the metabolic centres in both of these groups to identify the patients and let them know whether we think you should be considering these shielding measures. And Elaine Murphy and my other colleagues are going to talk a bit more about that next. Next slide, please. And just finally, here's some data again showing that this is a disease where the vast majority of us are likely to get very mild symptoms. So this is looking at different age groups of patients, the number of patients with symptoms who are going to need to be hospitalized, the number who are going to need critical care, and the fatality ratios, and they are much, much higher in older patients. In younger patients, they are much less, and this is only for patients who we've tested. So as you say, we're probably not testing maybe 50, 60, 70% of patients, which will make these numbers even slower. And I saw something in the papers today suggesting that the overall mortality in all age groups for this disease is almost certainly going to be considerably less than 1%. So next slide. I think one of the most important messages we can give you is that most people, and most people with inherited metabolic disease as well, are going to have a mild infection and make a full recovery. And that we're all being asked to take extraordinary measures, not because we're trying to protect ourselves, but because we're trying to protect other people and trying to protect our healthcare services from being overwhelmed just by the fact that this is an incredibly infectious virus and vast numbers of people are going to have it. And even a small percentage of a vast number of people is enough to overwhelm things. So I'm now going to hand over to my colleague Elaine Murphy, who's going to talk a little more detail about the measures people have been asked to take. Next slide.
Thank you, Robin. So I'm going to continue along the theme of how we prevent the spread of coronavirus. And although we've all heard a lot over recent weeks about social distancing, we thought it was worth putting up this slide again and just going through the measures in detail. So these are the measures that everyone should now be trying to follow in order to protect the vulnerable. So we're asking everyone to avoid contact with anyone who has symptoms or is known to have coronavirus. We want you all to avoid the non-essential use of public transport when at all possible. Anyone who can work from home, please try and do that and speak to your employer. We're all being asked now to avoid both large and small gatherings in public spaces, including noting obviously that now pubs, restaurants, cinemas, etc. are closed. I think this will be easier to enforce. We're also being asked to avoid gatherings with our friends and family. So to find other methods of keeping in touch rather than face-to-face in small gatherings. If at all possible, we are cancelling routine outpatient appointments to hospital to avoid bringing many people into hospital. And your GP may be doing the same. So only those people who we think are essential, we're asking to come to hospital. And for others, you may be contacted and asked to keep in contact with us either by telephone or through email or other online services. And it's really important to state that everyone should be trying to follow these measures. Next slide. Social distancing, as we've heard, is particularly important if you fall into one of the more vulnerable groups. And we've seen the data showing that that includes those aged 70 or older, or even those who are under the age of 70 who have another underlying health condition. And there are also some special guidance for pregnant women. Next slide. From this week, again, you've seen from Robin's slides that the government, the NHS and your metabolic teams will be asking some people who we consider at even higher risk of severe illness from COVID to follow even more stringent procedures. We will be trying to shield or protect these people completely from being exposed to or catching the virus at all. You will receive a letter or a text from the NHS. This will likely come from your metabolic team, but may also come from your GP. And those letters are being sent out over the next coming days. Within our own patient group of individuals with inherited metabolic disease, we will be picking out those who've had a solid organ transplant. So for example, if you've had a liver, kidney, or heart transplant. We will also be picking out individuals who've had a recent stem cell transplant or bone marrow transplant. We will be identifying patients who have an inherited metabolic disease and a severe respiratory condition. And we've already spoken about conditions such as Pompe, particularly those individuals who are already using non-invasive ventilation, and some individuals with airway disease, including individuals with mucopolysaccharidosis. Obviously, you will see inborn errors of metabolism on this list, and it's very important that we understand that these measures will not be applicable to the majority of people with an inborn error of metabolism. We will be specifically identifying those people that we think most at risk. So you will be contacted at some point this week if we feel that you fall into one of these groups. And many of us have already been speaking to some of these patients over the last preceding week. Next slide. The stay-at-home advice for these extremely vulnerable individuals will be difficult. There's no two ways about it. So if you are considered vulnerable, if you receive contact from the NHS, from your metabolic team, suggesting that you should stay at home and avoid face-to-face contact with others, we will be asking you to do things like this. To minimize as much as possible any time any vulnerable family member, so either you as the patient or if it is your child with IMD, spend in shared spaces with any other members of the family. And they will include your kitchen, your bathroom, your sitting area. You will be aiming to keep 2 meters away from all vulnerable people as much as possible. That may mean sleeping in separate beds or bedrooms, using separate bathrooms, and if you have only one bathroom in your house, as a minimum, using separate towels and linen. If you've got to share a bathroom, then think about letting the vulnerable person use the bathroom first, and then everyone else in the family, and giving the bathroom a thorough clean before the vulnerable person needs to use the bathroom again. Next slide. If you share a kitchen, try and avoid using the kitchen at the same time as the vulnerable person is present. If at all possible, they should take their meals back to their own room to eat. If you have one, try and use a dishwasher to clean and dry your crockery and cutlery. If not possible, then wash them well, using plenty of washing up liquid and warm water, and dry them thoroughly, again with a separate tea towel for the vulnerable person's crockery and cutlery. We do understand that it will be difficult and indeed almost impossible for some people and families to separate themselves from others at home. And this is going to be particularly difficult if you have a child with IMD or if you're an adult who is completely dependent on others for their care. You can only do your best. There is no more you can do. You can do your best to follow this guidance. And if you can't follow it meticulously and to the letter, then as a minimum, everyone should be as careful as they can. Washing their hands very regularly with soap and water, avoiding touching your face, and avoiding spreading it around surfaces, so keeping your surfaces clean. We also recognize that there may be some very vulnerable people who may perhaps already know that they are towards the end of their life, who will feel that these measures are too stringent and will impact very negatively, perhaps on their last months of life. They may choose not to follow this advice, and that is absolutely fine. This is a voluntary choice. Next slide. If you live alone and get a letter and feel that you're an extremely vulnerable person, you will obviously be concerned about where your care will come from. How will you get your medications, your food, etc. delivered? We have been told that as of tomorrow, this website will open. So this is a gov.uk website where you can register and let the government know that you're an extremely vulnerable person and that you will require additional help. And this will include if you live alone or if you are the carer of a vulnerable person but feel that you will not be able to manage on your own. So we would encourage you to register on this website. Next slide. One of the most frequent questions we've been getting over the last few weeks is whether the NHS is going to be able to ensure that there will be no medication shortages over the next few months. So we'd like to reassure you that the BIMDG, that's the British Inherited Metabolic Disease Group pharmacists, have a UK-wide network. They communicate very regularly and had a meeting last week. As of now, there are no shortages of any critical specialist medications in the UK, and that includes medications for urea cycle defects, such as sodium benzoate, sodium phenylbutyrate, glycerol phenylbutyrate, and other important medicines like betaine, biotin, and carnitine, which may only be coming from the specialist metabolic centres. Similarly, we're not aware of any shortages of essential dietary products, such as glucose polymer, which many people use for their dietary emergency regimen. I'm pleased to say that several pharmaceutical companies have already communicated directly to us that they do not anticipate shortages, and this may be one situation from which we have actually benefited from the preparations that have been put in place for Brexit and the contingency plans that pharmaceutical companies made to ensure a steady supply of all their products. Next slide. Some people have wanted to order a larger stock of medication just in case. We would really strongly encourage you not to try and do that. We have all seen what has happened when individuals have tried to stockpile food, and we know that there are a few people in the country who have more pasta than they can ever eat in their cupboards, and others have little or none. We will not allow this to occur with medications. Fortunately, the metabolic pharmacists will know when they have last dispensed medications for an individual, and so they will be able to control demand and supply. Because of their network, they know where medication is at any one time, and if one hospital pharmacy runs out, then medication can be moved around the country from one pharmacy to another as it is needed. Of course, unfortunately, as with all services, the pharmacists may be short-staffed, so please don't leave your requests for repeat or renewal prescriptions until the very last minute, but perhaps add an extra week or 10 days so that we give the pharmacists time to get everything organised. Next slide. Individuals have asked, what will happen if I am self-isolating? So self-isolating means you are in your home because either you or someone else in your household has symptoms or confirmed COVID-19, and you've been asked to stay at home and not have face-to-face contact with others. What will happen here may be slightly different from metabolic centre to metabolic centre, but broadly speaking, medication that might have normally been dispensed to you from your hospital pharmacy may now be delivered to you by post instead. And that is what our hospital pharmacy has done because they do not wish people to turn up in person at the hospital. If you have normally been collecting your medications from a local pharmacy or GP surgery, then start thinking now about who would collect this for you if you were isolating at home. A friend, a neighbour, another well family member. Ask people to support you. There are a large number of volunteer groups getting together now to support people. And we've already seen that website that will be hopefully up and running tomorrow. And this is particularly important to feel that you can reach out if you live alone. Next slide. A number of individuals with inherited metabolic disease, those with lysosomal storage disorders, receive regular enzyme replacement therapy infusions, often delivered by a home care nursing team, and have asked us what is going to happen with this service. Over the last few weeks, we have been making arrangements to continue with a home care delivered ERT for both children and adults, if at all possible. We do recognise that for some patients, there may well be some interruptions to treatment. This might happen if there is a shortage of home care nurses, if some of the nurses are affected or self-isolating. It may also happen because the patient or a member of the patient's household is self-isolating, because in that case, we will ask the home care nurse not to visit the home and give the infusion. To hopefully reassure you, we feel as a group that for some conditions, the risk of missing a few enzyme replacement therapy infusions will be very low to you. And this would include some conditions such as mucopolysaccharidosis, Pompe disease in an adult, Gaucher disease type 1, Fabry disease, and lysosomal acid lipase deficiency in an adult. Next slide. If we do run into trouble, particularly with regard to the resources around having enough home care nurses to able to provide the service, then there are a number of conditions for which we will prioritise enzyme replacement therapy. And these have been agreed nationally by the paediatric and adult centres. So we will be trying to maintain regular ERT in particular for these conditions. Pompe disease in a child, LAL deficiency or Wolman disease in a child, type 3 Gaucher disease, some patients with MPS who are currently being prepared for a stem cell transplant, individuals with Niemann-Pick disease type B who may have lung involvement, and those who are receiving intrathecal or spinal ERT. The bottom line is here, we are going to be balancing risks and benefits across our entire patient group at all times, but we will do our best to keep the ERT service going. Next slide. So what are some of the practicalities that might happen with regard to home care ERT? So if you are well and everyone in your household is well and no one is self-isolating, we're trying to organise that you receive your infusions as normal. You may be contacted by your home care provider just before they call to answer some additional questions, and they may give you some instructions. Next slide. If you are self-isolating or if another member of your household is self-isolating because you either have symptoms of COVID or because you know you have COVID, then nurse visits for ERT infusions will be paused for the duration of which anyone is self-isolating. This is to protect the home care nurses and to prevent spread by home care nurses across the community. So you should therefore inform your treatment centre if you are self-isolating, and also let them know when you're ready to resume infusions. So again, the bottom line is, if you or a member of your household is self-isolating unwell, let the home care teams know so that they do not visit your home. Next slide. Some of you have asked whether the home care nurses will be wearing full personal protective equipment, called PPE for short. All home care nurses will be following the latest NHS guidance, and at present this does not include full face masks. Remember that they have a duty of care not to attend your home if they have symptoms. We are aware that some patients are already choosing to interrupt their enzyme replacement therapy, what we call a drug holiday, so as not to have any outside visitors or nurses come to their home. If you choose to do this, you will be supported by your team. We do think it's best you discuss this decision with your team first so that any risks and benefits are clear to you. And this is obviously particularly important if you're making this decision on behalf of a child. Next slide. Some individuals are completely independent with their enzyme replacement therapy and do their infusions on their own without requiring a home care nurse. And they're wondering what will happen with their ERT. The plan is that they will be able to continue their ERT as normal. So ERT will be delivered to the home and they will do their infusions on their own or with a family member who is trained to do it. There therefore may now be an option to train some people who are currently requiring home care support to become either partially or completely independent with their infusions. Obviously, this is going to be very much staff resources permitting, and we don't think we're going to be able to arrange large-scale, rapid training. But if you wish to attempt to become semi or completely independent with your enzyme replacement therapy infusions, please discuss this with your metabolic team. Next slide. What about enzyme replacement therapy for extremely vulnerable individuals? Obviously, for extremely vulnerable individuals, what we are asking them to do is to minimize completely face-to-face contact for at least the next 12 weeks. So there are a number of things we need to think about here. Some patients will be offered or may choose a drug or enzyme replacement therapy holiday, so they will skip their infusions for the period for which they are being shielded. For other conditions, there may be an alternative oral or tablet therapy so that you could switch from an intravenous infusion to an oral or tablet therapy instead for the duration. Please discuss this with your metabolic team if you wish to consider this. If individuals are completely independent with our ERT and doing their infusions themselves, they may be able to stay at home and be shielded, have ERT delivered to the door, and continue giving their infusions. In some situations, and this is likely to be applicable generally to children, it may be decided between you and your metabolic team that it is best that you do continue with your enzyme replacement therapy. This is going to be an individual patient-by-patient decision, and again, it is best that you discuss this directly with your own metabolic team. Next slide. Some individuals who have regular infusions have a central venous access device called a portacath and are wondering what will happen if there's an interruption to their enzyme replacement therapy. These devices will continue to need to be flushed, otherwise they will become blocked and unusable. So what we will be doing is arranging flushing at the longest interval possible in line with the specific guidance for your device as needed. So again, your own individual metabolic team will be in touch to discuss this. Next slide. There are other groups where we need to think specifically about what the advice might be for them. So a number of you with MPS, mucopolysaccharidosis type 4A, are on regular Vimizim, enzyme replacement therapy, via the NHS England Managed Access Agreement. We have been told that we will receive specific guidance from NICE and NHS England in the next few days, and your team will therefore be in touch to discuss this. We expect that the need to attend for regular assessments at the hospital will be postponed, but we hope to be able to continue your therapy as usual. There are other patients who have only recently been diagnosed and are waiting to start enzyme replacement therapy. Decisions regarding this group will be reviewed individually by your metabolic team. It may be decided that some patients would be best to start therapy, whereas others may have treatment delayed. And again, this will be an individual decision. Next slide. So I think I've just had a text from Dr. Vara, and I don't think she's going to be able to join us. So Dr. Jones, if you're online, do you want to talk through some of this? Otherwise, I can keep going. Thank you.
Yes, thank you, Elaine. So some patients with inborn errors of metabolism have emergency regimens that they use when they're unwell to try and help reduce the risk of a metabolic decompensation during an acute illness or infection, which obviously includes COVID-19, but isn't restricted to COVID-19. And we must all remember there are lots of other very routine, normal viral and bacterial infections around at the moment. If you need an emergency regimen, then you will have been provided with one by your metabolic team. So if you have one or have been given one at one point, then you need one. If you haven't been given one, then you shouldn't need one, so you don't need to panic. In general, these are provided for patients with urea cycle disorders, fat oxidation disorders, some glycogen storage diseases, maple syrup urine disease, and the organic acidemias, which include MMA, glutaric aciduria type 1, and propionic acidemia. If you're not sure, again, contact and discuss this with your metabolic center. But in general, if you need one of these emergency regimens, you will have been provided with one. If you have not used your emergency regimen for some time, make sure you know where the document is. You're normally provided with a sheet of paper, and so find it, make sure it's available, and carry it with you. You shouldn't be going out of the house very much anyway, but keep hold of it because you never know when you may need it. We would ask that you, if you're unwell, that you may need extra medications or the dietary supplements like the glucose polymer powders to use during your emergency regimen, and make sure that the stock you have at home is in date and is able to be used. If you aren't able to find some in the house, or your stock is out of date, then contact your GP, your local pharmacy, or your metabolic team urgently, because you do need some, as the purpose of these emergency regimens is to keep you well during your intercurrent illness or your infection, whatever it is, whether it be COVID or whether it be a routine normal infection, and to try and prevent you needing hospital admission and hospital treatment, which is, of course, always the aim, but even more important during these times. So keep everything handy. Make sure you have your documents with you. Make sure you have your contact details for the metabolic team, and that you have all that you need in terms of glucose polymers, and these come in different forms. Just make sure you have enough for at least a few days. Next slide, please. So if you are unwell, you have one of these diseases that needs an emergency regimen, and you are not tolerating this. So if this is, if you like, the plan B, so you're on your glucose polymer, drinking it at home, and then you're not able to tolerate this, usually because you've got a vomiting bug, or because you have a child who's just not able to drink these at all, then the next step normally and currently is to attend your local hospital. Of course, in an absolute emergency, if there's a life-threatening situation, you can call 999 as you normally would, or follow your normal guidance and approach to attend your hospital. So that may be attending A&E, or it may be phoning a direct admissions unit and going straight in. If you do have to go to your local hospital, that would be usually if you require intravenous glucose and intravenous fluid support, then please bring everything with you as we would have asked normally. So that's your documentation, your glucose powders, etc., and any medications you may have, contact details for the metabolic team, as you normally would. I think this is important. Your local hospitals may well have different guidance to how they normally would in different systems in order to manage COVID, but they should be able to cope with you also. Next slide, please. So in terms of child, if your child has an inborn error and is unwell at home, then absolutely commence your oral emergency regimen as normal. We would ask you to contact the metabolic team through the normal routes. And of course, if your emergency regimen is not tolerated at home, as we've said, then you would follow your normal, usual open access procedures. You would go in for your intravenous treatment, assuming the child has no respiratory symptoms. If your child is unwell, not tolerating the emergency regimen, and has breathing difficulties, a cough or fever, in other words, some of the symptoms that could relate to COVID-19, then they may well be managed differently. So not that the metabolic disease would be managed differently, but the respiratory symptoms and the management of a potentially infectious patient in hospital may need managed differently. And so we're asking in this situation that you speak to your metabolic team, who can liaise with your local hospital and discuss how and when you should attend, so that this is done properly. In hospitals in a COVID epidemic, it's likely that potentially infected patients with COVID-19 will all be nursed in a similar place. And so they may well be handled differently in terms of the logistics of where they go. Of course, it's important that we manage the respiratory symptoms and the infection risk, but of course we need to continue to manage the metabolic disease and prevent decompensation as normal. So I would advise, we would advise this stratification and this difference when you're managing your children with metabolic disease. If you have an advanced care plan for end-of-life care, then most of these will still be entirely applicable and should not change. However, if your child is deteriorating or unwell and you have an advanced care plan and you're not sure, then again, contact your local community team or the metabolic team once again. And of course, as we've said before, if there is an emergency and a life-threatening situation at home, you can always call 999 as you would before. Next slide, please.
Simon, through this one. So, all right. Hopefully you can hear me. I've lost visual. If you are an adult with an inherited metabolic disease and you require acute care, the advice is very similar to if you are normally unwell. Commence your oral emergency regimen as usual. Contact your metabolic team as usual. If you don't tolerate your emergency regimen at home and you think you need hospital care, then present to your local hospital accident and emergency department as usual. Bring your metabolic team contact details with you so that they can be called for advice. Everyone presenting is going to be screened and asked questions regarding COVID-19 on arrival, but emergency care will be triaged as usual, so with the most urgent cases being seen first. And remember that, again, you can still call 999 in an emergency. Next slide. Back to you, Simon.
Thank you, Elian. So the guidance that we've discussed before, that Robin and Elaine have talked about with regards to social distancing and social isolation, I think applies, if not more so, to families and children with inborn metabolic disorders. And so we would advise everyone to follow the ongoing government advice, and as this changes over the next few days and weeks. So social distancing is really important in reducing infection and self-isolate as much as possible. But of course, we recognize that within families, if there was a particularly unwell child who was cared for by a number of other members of the family, or indeed carers coming in from the outside, this can be difficult. Of course, we would want you to try and isolate the child or the individual with an IMD as much as possible, particularly if they're in one of those vulnerable groups that we talked about before. But we recognise that as carers, this can be very challenging. Do try and follow the advice. It may seem impossible, at least to do this perfectly, but very much so here, perfection is the enemy of the good, if you like. Try and do it as well as you possibly can, and don't just give up if it's actually impossible to do all of the advice. Follow this as much as you can. There may be neighbours, friends, relatives who can help out, and we want to think about those with higher risk, and it can be difficult for us to be really specific about all of those, but we would certainly include those at risk of serious metabolic decompensation, which would include those at risk of raised ammonia. So that would be most of the urea cycle defects and the organic acidemias, and those at risk of other neurological deteriorations like the maple syrup urine disease children with glutaric aciduria type 1, the fat oxidation disorders, the vitamin B12 disorders, and many, although not all, mitochondrial diseases. The other group that we would think about particularly would be those with significant lung, airway, or neurological disease. And again, that includes most children with Niemann-Pick A or B because they have lung disease. Some children and young people with MPS or mucopolysaccharidosis, but particularly those, so not all of those children by any means, but particularly those who've got severe lung or airway disease, especially those who are on non-invasive ventilation at night, for example, CPAP or BiPAP. Those children would be undoubtedly specifically at risk. And then there's a broader group that is quite hard to define, but really we categorize as those with severe neurological disease caused by a number of different inborn errors of metabolism. And those children, because of specific issues with coughing and clearing their own secretions, have specific risk from their lungs, even though the primary disease is in the brain. And again, despite all of this warnings and worry that we know you will have, clearly the evidence as we currently have it is that COVID-19 is a mild infection for the majority of children. And so most children, even those with inborn errors of metabolism, should be able to cope with COVID-19 as they would any other infection. Next slide, please. Just a short segment for those children, young people, and those in our community involved in research. So we're a very research active community, and many of you will be in or have been in a research study at some point or another. There's really two categories of research study that we'd like to think about currently. One, a type of study that many of you will have been asked to be in at some point, where we take extra samples of blood or urine during routine clinic visits, or we ask that we share your data with a registry, or we capture specific data on what's called a natural history study. These are what we think of as mostly observational studies. We're not delivering or changing your actual treatment. We're just trying to understand these rare diseases better. These studies will in many ways be suspended during this period of time, but you don't need to do anything. We just won't be entering data or carrying on or arranging special visits during this time, because this is not essential to you and your care. But there was another group of studies that are more difficult, and these are the studies where children, young people are on a specific trial that delivers a therapy, either a new therapy, a different therapy, or the only therapy for their underlying disease. And in some of these cases, at least, it would be viewed of as particularly risky or difficult, and perhaps not in the best interest of the individual to stop that trial, because that would stop a potential treatment. This is difficult, of course. These are not licensed treatments in general, and we don't know everything about how effective they can be. Our research team's going to be affected. Many of you will have research teams linked to your IMD clinical team, but many of you will also be involved in studies that have a specific research team. Just like every other medical team, however, throughout the country and the world at the present time, There may be staff shortages, either because staff become unwell or they have to self-isolate, or because staff in research teams are drafted in to help clinical teams manage in this very, very exceptional time, as many of our research nurses and doctors are highly skilled. This is somewhat unpredictable at the present time, but most of us involved in doing research studies at the present time have already been through all of our trials and looked at those which are critical to continue because they deliver a critical treatment, and those which we may be able to put on the back burner for a period of time. And in general, they followed the categorization that I've given, and you should be contacted by your research team about some of the changes to your trials. Even if a trial is continuing, there may well be changes to how this trial is delivered. You may be coming in less often to the hospital or research site to try and limit exposure. Visits may change, there may be less invasive sampling, and we may be doing more assessments over the phone to try and again manage infection risk and limit exposure. We may be asking you, if you do have to come into hospital, to change when you come in. We may have to postpone treatments, and we may have different places and systems and logistics for delivering some of these trials, as hospitals are indeed gearing up for, as Robin and Elaine have said, for a really quite unprecedented number of patients requiring really very intensive and specialist care. So for the trials that are critical, we hope to carry on. For those that are less critical for day-to-day care, those trials will be on the back burner, but will be reactivated once this period of time is over. I hope that's clear. And next slide, please.
So we've already heard how we can work together as society to help stop the spread of coronavirus, but we also need to think about how we can work together as a smaller IMD community. We have to be realistic. There is likely to be staff shortages across all teams. In adult care, we expect to be particularly busy. So it is very likely that our metabolic nurse specialists will be redeployed to the general hospital wards, and so may not be able to answer telephone calls and queries as quickly as they may have been used to doing. It's also likely that our administrative staff may be redeployed to cover essential tasks. Some of the doctors, again, particularly in adult medicine, have general medical or other qualifications and are going to be called upon to support their colleagues in the hospitals where needed. We really want you to keep in contact with us as you need us, but you can also help by getting organised now while we are all still at work in a normal way with your medicines, supplements and emergency regimens. Before you phone or email us, check if the answer is available somewhere else, either online, the government or NHS websites, or from your patient support organisation. I think probably trust yourself. You've been used to dealing with your metabolic disease. You've been used to dealing with your child's metabolic disease. Your gut instinct about what to do will probably be correct. I'm afraid we'll have to apologise. I think there's going to need to be some flexibility about things like the days of administration and the frequency of enzyme replacement therapy infusions, perhaps regarding blood spot reporting and essential hospital appointments, etc. We've already discussed many of these will be moving to telephone-based appointments if they can. Next slide. Apologies. So many individuals with IMD have regularly prescribed medications or dietary supplements, and we would consider you to be generally well and healthy. And so we found it was important to give a list, and it's very much not an exhaustive list, of conditions where we really feel that the risk is not any greater than that for the general population. So broadly speaking, this list includes all individuals with phenylketonuria who don't have any other separate health condition, and we will be in separate contact with women with PKU who are pregnant, those with homocystinuria, galactosemia, trimethylaminuria, familial hypercholesterolemia if you don't have any heart disease, well-treated patients with Gaucher, patients with hyperthyroxanemia, and women with Fabry disease who don't have any significant heart or kidney involvement. And although this list is short, it actually makes up a large proportion of the patients with inherited metabolic disease that we see in clinic. So if you have one of these conditions, you should simply continue to take your treatment as prescribed and follow the NHS advice for the general population. And again, we apologise, but it is likely that some of your routine metabolic care will be temporarily delayed or disrupted. Next slide. Please make use of all the very good internet resources out there, but be careful, obviously, of unreliable sources. So your patient support organisations should be your first port of call, the government and the NHS websites. In a minute, Lynn Aikenhead is going to give us a little bit more detail about mental health support, and again, there is some very good advice online. Separately, the LSD Collaborative, looking after patients with lysosomal storage disorders, will send you out more written information later this week regarding clinical support and home care treatments. And these have been agreed. Next slide, if possible.
So hi, I'm going to say a little bit about the psychological impact of the issues that we've heard about related to COVID-19 that have been discussed already today. So I know that everybody is feeling very worried and anxious at this time with everything that's going on. I'm going to say a little bit about some of the kind of difficult and challenging feelings that you might experience. It's not an exhaustive list, but you know, a lot of people will be feeling very anxious, especially if you are in a high-risk group or somebody that you care for, a member of your family is in a high-risk group. And that might include being worried about your health or their health, about how you're going to manage to get day-to-day things done at the moment, or about how this situation is going to develop in the future. They might be feelings of sadness and feelings of loss about some of the things that aren't happening or can't happen, about some changes in your plans at the moment or the situation that you're in. You might find yourself feeling guilty. Perhaps we've heard about how some of the measures that are recommended are very difficult to achieve. We've heard about how important it is to do the best that you can in that situation. You might be thinking about what you should be doing, what's the perfect solution, or comparing yourself to some of the other things you see, especially online and on social media. And for lots of people who are self-isolating or social distancing, you know, we know that being relatively more isolated causes some difficulties. You know, really commonly people find they feel bored, they feel more irritable and fed up with the people who are around them, more frustrated. They might find that they start to feel low in mood or demotivated. All of those feelings are really normal. All of those feelings will fluctuate up and down, and there'll be some good times and some worse times. They're likely to be particularly intense if you become seriously unwell or someone you care about is seriously unwell. And if they are really having a significant impact on your life, if they're feeling overwhelming, not getting any better, or stopping you from doing things that you need to be doing, then that's when you might want to think about getting some more help and support. And I'll talk in a couple of slides' time about where you can find that. We can just go to the next slide. There's a few strategies here that might be helpful in coping with those feelings. So the first thing I've suggested is making sure your expectations are realistic. Like I said, we've heard about how some of the measures are difficult, but everybody should be making sure they can do the best that they realistically can. I know that there's a lot of things circulating. For example, I've seen on social media loads of beautiful color-coded timetables with slots on them for mindfulness meditation and affirmations and healthy snacks. And that's great if that's you and you can make and stick to that kind of schedule. For the rest of us, I think we're going to have to be a bit more flexible in coping with the demands that this situation throws at us. I've suggested taking some time to prepare, because if a situation does arise that's really stressful, it will be easier to cope with if you have given it a bit of thought and planning before. So for example, if you're caring for someone, it's really helpful to set aside some time to plan what will happen if you become unwell, to think about who else can help you if you need some extra assistance, and to really focus on the bits of the situation that are in your control. A lot of this situation is outside of our control. You might even want to sit down and write a list of which things are in your control you can do something about and which ones aren't right now, to help you focus your energy in the right place. It's always helpful to talk to other people about how you're feeling. That might be online now as opposed to in person. And if you are caring for somebody, perhaps a child or somebody with some cognitive impairment, it can be really helpful for you to be modeling that in front of them, to show them positive, constructive ways of expressing the way that you feel. If you are caring for somebody like that, you also might want to share information with them about what's happening in a way that is easy for them to understand. So that might mean, breaking the information down into small chunks, simplifying a bit, repeating it. I would always, advise being honest with people, but they might need a bit of help to understand the changes that are happening and why. I think it's also helpful to be prepared that any stress or any big change and upheaval in routine can exacerbate some symptoms of metabolic disorder. So you might find that some difficulties are worse than usual or are fluctuating more than usual. That might be true for any symptom, but especially for perhaps cognitive difficulties, behavioural or emotional difficulties that are associated with your metabolic disorder. And I would suggest for everybody to try to make sure that they prioritise and practice good self-care. I always use the same analogy about when you're travelling on an airplane. They always tell you to put your own oxygen mask on first before trying to help someone else. I think the same idea is true in this situation. So it's really important that you take care of yourself so that you have the resources you need to help someone you're caring for. And you'll have read a lot online about how important routine is. It is important to try to stick to a basic kind of routine. So things like getting up and going to bed at the same time every day, having regular meals. We know that that's important for your general health and well-being. And we also know that making time for some activities that can boost your mood or support your mood is also really helpful. So that might be some physical exercise that you can do or other activities that you're able to enjoy. And if we just go to the last slide, there's some ideas here about where you can get more support. I've seen that we have got some people signing in from outside of the UK. I'm afraid that most of the places I can suggest and recommend, they're for UK-based folks. So you can contact your metabolic centre, who might have a psychologist. Some centres here do have a psychologist. If they don't, they should be able to point you to where you can find psychological support somewhere else. You can make a referral for yourself if you're having a mild or moderate difficulty, for example, with feeling very anxious, to your local psychological therapy service. There's one in every borough in the UK, and to find yours, if you search online for "can I get free therapy or counselling," you'll be able to enter your postcode and find the telephone number and the website for the service local to you. You already know that a lot of the service user organisations for people affected by metabolic disorders have got resources to support you. So, for example, Metabolic Support UK, LSD Collaborative and others. You've also seen that Mind provides support and information with people who are experiencing mental health problems. They have some useful information on their website about what to do if you're concerned about someone else's mental health or about your own mental health. And lastly, for those practical kinds of preparations, Carers UK have some really good resources about how to make a caring contingency plan, what might help you if you have professional carers coming into your home, and how you can get more support with caring, for example, from adult social care or child social care. And I'm just going to hand back to Will to finish things off.
Thank you, everybody. We've obviously run over the hour, and there have been lots of questions being posted. I think one of the things which I think is an important message to say is we're talking about lots of different diseases, and also diseases which are quite variable from one patient to the next. So to be able to give specific advice for each patient would be impossible in this format. And I think I'll reiterate the message that we started with, that those specific questions about risk and decisions that one should make should be made between you and your treating physician. There were a couple of sort of general questions that came out that might be worth specifically addressing. One was about shielding in Scotland, and whether that's something that's happening there. My understanding from Nicola Sturgeon's speech yesterday was that she indeed discussed about shielding and followed very similar to the lines that were then later announced in England and Wales. So information in regards to that would be on the NHS Scotland webpage. And then there is another question that I think might be quite useful just to address as well, which was, and perhaps I could ask members of the panel to address this, was if you don't receive a letter by the end of this week, should one consider yourself in the not especially vulnerable and therefore need to shield group? Perhaps I can ask one of the panel members to address.
I can try and have a go at that. I think NHS England has admitted that they don't have the amount of data they need to be able to identify everybody and get their GPs to write out. So there are some people who will definitely be getting letters from their GPs, and that's probably people who've had organ transplants, because we know about that, and some other things. As I've said, we are certainly from our centre are going through our lists of patients and trying to decide who we think are highly vulnerable and should be shielding, and we will be getting in contact with them either with a letter or by phoning them. We will do our best to do it as quickly as possible. I think until you hear something, the decision is very much up to you, what you do, but shielding is really quite extreme, so you might want to continue to self-isolate and make other decisions. We will do our best to get in touch with everyone who we think fulfills these criteria as quickly as we can, and would encourage people to wait. But if you are particularly concerned, try and contact your clinicians, and I'm sure they will get back to you as quickly as they possibly can.
Thank you, Robin. And also, there's obviously the patient support groups as well, who, although I would be unable to give you specific clinical advice or is deferring to physicians, certainly could direct you towards the resources and be able to give you general and generic and up-to-date advice as well. If we just move on to the next slide. So I think hopefully people have found this very helpful. Certainly I have, and it certainly was no small undertaking to put this all together at such a short period of time. So I'd like to say a big thank you to especially Metabolic Support UK, the LSD Collaborative, and the British Inherited Metabolic Disease Group for putting in so much work to bring this together. We've had almost 500 attendees, participants on this, which obviously shows the level of interest and need for this. And a big thank you to all members, the experts, all members of the panel for taking time to be able, out of their busy schedule, to be able to address lots of our questions. So with that, the important message to say is, although this is a scary, unprecedented time, I think some of the take-homes that I've got is that even those often with significant health problems, in young individuals, this really is a disease that tends to be worse in older people. And no matter how difficult the next number of months is going to be, this will pass. And with the support and of ourselves and the groups and the healthcare system and our communities, I'm sure we will all get through this and return back to normal life again. Thank you.